Obviously, for infections, when you're treating homeopathically, you're not treating the organism, you're treating the context and the host response. You're trying to mirror or optimize the host response to infection. And different infections have got different locus and different tissue affinities. And so, broadly speaking, your viral infections have a different pathological evolution to the bacterial ones, and sometimes there can be entanglements between both. Different remedies, some have affinities for mucous membranes, some of them have got affinities for glandular structures like pulsatilla, as you know, exocrine glands. Some of them have got affinities for the endothelium or have got affinities for interstitium. Some are more respiratory remedies, some are more skin remedies, some are more GI or GU remedies. You met cantharis, for example, for acute florid hemorrhagic cystitis, where there's strangury and urgency. And there are others, as sarsaparilla and copaiba, where for example, there isn't blood in the urine and there's less pain. Causticum for the painless frequency of UTIs in old people. So causticum as a UTI remedy, urinary tract infection remedy, in people who just have got frequency and maybe a bit of loss of bladder control but don't have a lot of pain. So the symptom picture of the remedy guides you to its tissue affinities and gives you some indication of the crossover. There are one or two pairings that you should know between the nosode and the most commonly used simillimum. One of these is for staphylococcal infections. So the nosode is staphylococcinum or staphylococin. That is the nosode of a Staphylococcus aureus. And the simillimum is often Hepar sulph. And you will, generally speaking, whenever you're treating an infection, treat with the simillimum first and the nosode second. The first thing that should go in is the simillimum, because the first thing you want to do is to try and switch on the body's own endogenous immune response by optimizing the physiological reactions that are going on around the infection. That's what you want to try and do. So it's very rarely that you treat an acute infection using a nosode. Even if you know which organism it is, you nearly always use the simillimum first. So if you get, for example, a pneumococcal middle ear infection, you don't give pneumococcus first, you give belladonna. Bulging eardrums, heat, red, fever, what have you, right-sided, tense, throbbing pain, belladonna state, give the belladonna. You can thereafter, if you want to, give a coccal organism, or if you've got an etiological organism, you can give it afterwards. But with the Hepar sulph picture, you nearly always have pain. You have a loculation of pus. Sometimes it's in little boils or cysts, sometimes skin infections, and sometimes classically they're in an area where the skin is quite tight over bone. So you get a disproportionate amount of pain. These are small pimples, sitting over your mastoid process or sitting in your external ear canal, somewhere where the skin has lots of pain receptors, and where the skin is as tight as a drum anyway. And the slightest breath of air, the slightest touch, is excruciating because your pain nociceptors and fibres are already jangled. So Hepar sulph, associated with the loculation of a hot, active point, sensitive to touch, often with yellow pus. If you give Hepar, you can often promote an early discharge from that and a quick resolution. If you get it very early, before it's become cystic, and you give Hepar sulph, then often you can get the head to disappear, reabsorb, and the inflammatory process just to simply involute. So, depending on when you catch it, the Hepar will either promote a quick discharge and healing, or it will promote an early involution and resolution. And the difference between HEPAR and silica is that the silica tends to be a cold point somewhere, often in the deeper tissue, which is not known to the patient and maybe a bit erosive and quite insidious, whereas the HEPAR, if you've got a focus with HEPAR, you know about it, generally speaking. If you think about what HEPAR sulf is, it's a mixture of lime and sulfur heated up inside a crucible to very, 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 very high temperatures, volcanic temperatures. It's almost as if it wants to kind of explode with heat. That, to some extent, reminds you of the kind of intensity, the pain intensity and the heat that exists often in the very small HEPAR points. Generally speaking, very, very large abscesses are not HEPAR. Generally, if you've got pararectal abscesses and things that are very substantive and large, you're often not needing HEPAR. You're maybe needing snake remedies and mixed bacillary nosodes and other things. Those kinds of things with fistula formation and with gram-negative ingress, lots of gram-negative organisms. Probably not HEPAR sulf. It doesn't fit with the picture. So that's one pairing that you have to remember is HEPAR sulf and Staphylococcus.
So you said in acute pictures go with the cinnamon first, and then you could go with the nosode.
You can.
What about chronic pictures?
The chronic pictures, usually the chronic pictures that have had a load of treatment. And in the chronic pictures where you've got a sequelae of a known infection, then you use the nosode. So if, for example, let's say, for example, give you an example of a patient I saw early on in my career, a lady, Glasgow Homeopathic Hospital, with widespread psoriasis. And the psoriasis started just after parturition. She'd given birth to a child. She had a small spot, infective focus on her anterior abdominal wall. It was staphylococcal. It discharged, but the actual spot turned into the first plaque of psoriasis. And then the psoriasis then spread all over her body. And she then had years and years of treatment, light treatment and every possible treatment. Came to the Glasgow Homeopathic Hospital and I took the history again from the very first principles from the word go, gave staphylococcinum, and the psoriasis cleared from head downward. And when she came back 2 visits later, she had a patch on the dorsal of each foot, and that was it. And I've seen since then other patients with either a streptococcal or a staphylococcal trigger for psoriasis who've responded to these nosodes. And they've responded to the nosodes years and years and years and years after the infection originally disorientated their surface immunity. And that is a late sequelae of an active acute infection using the nosode. Some of these patients also respond to things like arsenicum iodatum or other classical psoriasis remedies in part, but where the etiological trigger is known and you get a good match, then you get a good response. You can find it with Staphylococcus and Streptococcus as etiological. If you have patients with uremic syndromes and or ascending infections with renal problems where you've known you've got recurrent E. coli appearing in the urine, then the nosode, the closest nosode, is either E. coli in potency or the bowel nosode mutabile. You can use those, and you can often get a reduction in UTIs and, within certain limits, some resolution and improvement in renal function. There is only one exception that I know of where reliably the nosode can be used almost acutely, and that's in the case of psychotic cold. Both the literature and my experience suggests that psychotic cold can be used almost acutely for certain kinds of respiratory tract infection where there's a known cockal organism. The other main partnership that you need to know is the relationship between Phytolacca and Streptococcus. So streptococcal hemolytic strep produces a very obvious clinical picture, but that clinical picture is very often very close to the picture of a Phytolacca acute. Phytolacca is a very poisonous plant, beautiful, deep red, scarlet berries on it. It's poke root, and it is, I think it's carcinogenic, and it is toxic, and it's really not a nice plant. It has all sorts of creates all sorts of immune disturbances.
Okay.
The symptom.
I've had Phytolacca acute before.
Sorry.
I've had Phytolacca acute before, but as a mouthwash to gargle with.
Right.
For tonsillitis.
Wow.
Is it dangerous?
No. Well, I mean, I've never heard it used in the mouthwash, but in
not mouthwash, sorry, just as a gargle.
Right.
For very bad tonsillitis.
Sure. I mean, I think probably if it's in potency, that's a very good reason for using it. So one of my uses of Phytolacca is in acute tonsillitis, and the picture for acute tonsillitis is obviously very red tonsils. The fauces in front can be slightly bluish and dusky, as can the pharynx, and there are nearly always tender, rubbery cervical lymph nodes. The glands in the neck are tender and sore to touch, and they're slightly hard. They're hard and slightly rubbery, and the patient themselves are slightly sweaty, toxic, and unwell, clearly unwell. There may be some trismus as well. There may be a bit of trismus as well. And it's very clearly quite a florid bacterial tonsillitis, most likely streptococcal. And in that situation, you give Phytolacca high and frequently, and if you want to, you can move quickly to streptococcus, and you can use even Phytolacca streptococcus if you've started the thing with Phytolacca or a couple of doses of Phytolacca. You can introduce intermittent doses of streptococcus into the picture, even in the acute or subacute. But the most important remedy in the equation is Phytolacca. So you will also see it in mastitis. In an acute mastitis in women, the thing about Phytolacca is that it has an affinity for the lymphatic network, including the lymph glands, and it seems to be that the inflammatory process in Phytolacca somehow goes through the lymphatics. And if you think about streptococcal, an ascending infection in streptococcus, where you get a lymphangitis, and where the lymph, you can actually maybe even see a lymphangitis, an ascending lymphangitis with a streak of red going up the leg, and swollen inguinal glands. That seems to indicate that streptococci have a route of ingress or a route of spread through lymphatic channels. And what the Phytolacca is doing is it's changing the defense mechanism inside the lymphatics, it seems to be. Now in mastitis in the breast, they drain toward parasternal and axillary nodes, and you may well find in a mastitis in breast, firstly, the breast looks slightly marbled. It may or may not look, there may be a slightly pink diffuse patch on the breast. It's very, very tender to touch. You put your hand on it and it's hot. It's hot underneath and it's very tender. And the woman is saying, oh, please don't touch me there. Oh. So hardness, blueness, maybe a bit of marbling, and somewhere tenderness in the glands associated with the drainage. Phytolacca in early 30s or 200s, and Phytolacca on its own may resolve that without recourse to using streptococcus. You might get a nice resolution, and I've got a number over the years of patients with Phytolacca mastitis. So the point to remember is that there is a pairing, there's a phenomenological pairing between Phytolacca and streptococcus. In the same way there's a phenomenological pairing between Hepar sulf and Staphylococcus. In the same way, there is an etiological pairing between glandular fever and ailanthus glandosa, and they represent almost specifics. So you can use these with confidence, use them frequently in acutes, use them in high potency, and you can't overdo it.
Sorry, if you use phytolacca, do you preserve the architecture of the breast?
As far as I can see, the thing turns back to, the inflammatory process resolves and the thing looks good. It doesn't loculate or produce cystic change. And the thing is that, when you're catching it early and there's this acute congestive thing, it hasn't turned into an abscess. There isn't breakdown in the tissue at that stage. So it's best treated early,
My wife has had mastitis 3 times. And we've used phytolacca.
Yeah.
So, as you can see there, that I've listed a whole load of remedies that kind of have different possibilities, infections, and I don't give you any real. I don't get inside them particularly to give you their individual indications, because some of them we come up with, and you're not expected to learn these all at this stage, and you're not. I mean, for example, the things like calendula for simple superficial cutaneous inflammatory problems, where there's been a contusion or a little bit of local injury, or where you've got a disruption maybe in the foot, for example, and an ingress of some mixed infection or some fungal infection. You can use things like calendula perfectly safely as a tincture, as a low potency, as a compress. And at foundation level, that's what we would be looking for, just that awareness that those things exist. We will talk about things like ranunculus bulbosus later on in the course, and things like herpes zoster, and silicea or silica. You might, if you occasionally include or have patients that have got a known apical root abscess, and they've got dentists who are wanting to drill and clear an apical abscess from one of their top teeth. If it's a cold thing and an incidental finding, you might want to give them a low potency of silica and keep them going there while they're waiting dental treatment, or just see if whether or not they can get some spontaneous resolution over time of it. Thuya, you need to know it's under fungal infections, and it should also be under viral infections, because Thuya is one of your warts remedies. That is an infection. You most often will use Thuya in fleshy pedunculated warts. Its greatest value is for those condylomata, often with warts that occur at mucocutaneous junctions. So little seedling warts around the mouth, vaginal and genital warts, genital condylomata, anal warts, where they're often this pedunculated fleshy appearance to them. They are the ones that respond best to Thuya. Also, to some extent, molluscum contagiosum. You'll get small kids who respond quite quickly to Thuya from molluscum. There are other treatments for molluscum. There are other things that work, like tuberculin and other things. But at the moment, and at primary care certificate level, you're not expected to know the constitutional image for Thuya. We cover that in the respiratory section of part 9 of the intermediate course. We go into a lot of detail around the Thuya picture. You can, of course, if you want to go and explore and look at that, but at the moment you don't need to know the constitutional image for Thuya. Just realise that, and I think even at primary healthcare certificate level, you're expected to know it as a cream. You're not even expected to consider it as an oral remedy. For plantar warts, you can use the Thuya as a tincture, or as a first dilution, and put it onto the plant of water, and then put an occlusive thing over the top. Most often it's duct tape. These days the podiatrist will say, "Well, cut off a square of duct tape and plaster the wart with it." But you can put in a dose or small quantity of thuya in there, and the occlusion of it seems to increase the speed of the primary immune response to the virus and get rid of the thing quicker. Anything else we need to think about? Rust tox is not a PHC remedy, but think of it for chicken pox. Okay, so you get an acute chicken pox and they're coming out with these vesicular things, and there can be some irritation and some in those that make the child scratch the top off them. And rust tox is a good simillimum for chicken pox. I'm not sure how much we see of chicken pox these days, and it's not as common as it used to be.
It still is.
It's still around.
It's right in the school, going around.
Right. Okay. Well, I think my chosen potency for rust tox is probably 12. You could give it in 30s. I think you could also give it in 6s, but I tend to give it in 12s during acute chicken pox, 2 or 3 times a day.